I'm James Giuliano, and I serve as Vice President of Quality Programs at the Ohio Hospital Association. Today's program is the first of a two-part series and will focus upon pre-hospital considerations in sepsis care, the first part today being recognition, the second part being on February 21st, where we will address treatment. Joining us on our call today are members of the OHA HIN, the OHA Statewide Sepsis Initiative, our pre-hospital care community, the Ohio Department of Health, and the Health Services Advisory Group. So welcome to everyone. Please know that you will be given an opportunity to type in questions through the chat box feature throughout the presentation. Questions will be addressed at the end of the presentation. Please also know that this presentation is being recorded and will be posted on our sepsis webpage, which you can visit at ohiohospitals.org/sepsis, and by clicking on the Education tab. There you will find all of the previously recorded sessions that do not contain data. This program has been approved for 1.0 contact hours of continuing nursing education. We know that this continuing education can be applied to a number of disciplines. You will be provided with a link to an electronic evaluation tool. You'll need to log on, complete the evaluation, and request your certificate. The evaluation process will remain open for 2 weeks from today to allow you the appropriate time to complete this process. However, if you have any questions whatsoever, you're welcome to call Dorothy Aldrich at the Ohio Hospital Association or email her. Her email address is on the screen. It's dorothy.aldrich@ohiohospitals.org. We are no longer using a fax submission option. It is now my pleasure to welcome a true leader, a researcher, and a clinician in sepsis care, Dr. Christopher Seymour. Dr. Seymour serves as assistant professor in the departments of critical care and emergency medicine at the University of Pittsburgh School of Medicine and the CRISMA Center, which stands for Clinical Research, Investigation, and Systems Modeling of Acute Illness. The CRISMA Center, a clinical, translational, and health services research group conducting cutting-edge research into the optimal care of the critically ill, was founded in 2001, concurrent with the founding of the Critical Care Medicine Department. Dr. Seymour completed his medical education at the University of Pittsburgh and holds a Master of Science degree in epidemiology from the University of Washington. His sepsis research has been funded by NIH, and he has several sepsis-related publications in major journals on sepsis. At this time, it is my pleasure to welcome Dr. Christopher Seymour. Chris, the floor is yours.
Thanks, Jim, and hopefully everyone can hear me okay. It's a pleasure to speak to this broad audience, and I'd like to offer my thanks to the Ohio Hospital Association for the invitation. Today, we were invited to speak mostly about recognition of sepsis during pre-hospital care, and so that's really going to be the focus of our agenda. I'm going to try to move the slides. To first, just some disclosures as we begin. As Jim mentioned, there are some funding sources which have included organizations like MedicaOne in Seattle, as well as some consulting there. And I'll note that I currently have sat on the board of the Surviving Sepsis campaign, which is offering clinical practice guidelines, mainly for inpatients with sepsis. Okay, so some caveats. I'm not an EMS clinician. I work primarily in an ICU at a hospital called Mercy Hospital in Pittsburgh, if anyone is familiar. I'm involved with a variety of different research and clinical efforts during pre-hospital emergency care, including a trial which we'll talk about called PitStop, which is administering pre-hospital antibiotics in Toronto. So with that, we'll get started. I think it's good to offer a case to sort of anchor us in a clinical scenario. But instead of pulling out a medical record or looking at a chart, this case actually comes from the New York Times. In that our lay press has been talking about sepsis now for many, many years. And as you can see in this text, this is describing a 58-year-old man who presented with a viral illness, something quite common at this time of the year. There was an unfortunate cascade of events, perhaps a misdiagnosis early during care, and this otherwise educated man with very few comorbidities developed aggressive organ failure, a prolonged stay in the ICU, and ultimately died of septic shock. And so this case should sound quite familiar to many of you in the audience. And we must think about, well, what happened back in 2002? Is that still happening today, 15 years later? And of course, the answer is yes. That many patients with sepsis, there's a delay in diagnosis. And there's a lot of variety in how patients present, in that there's different organisms and pathogens that can lead to sepsis, and often different organs that get affected. Some patients primarily have a CNS infection and therefore are presenting with encephalopathy and the confusion, whereas others may have hemodynamic compromise and shock. Was there treatment administered at that time without practice guidelines? And really looking forward, what are some of the things we'd want to do? Well, perhaps we'd like to identify sepsis and septic shock sooner, deliver aggressive treatment but without harm, and target that therapy to that Mr. Wilson and not a patient coming after him who might have multiple comorbidities and be of a different host fitness. And so our objectives today to line this up is really to go over what is sepsis, hopefully very familiar to those of you logged on. We'll discuss a little bit about why the definition and criteria for sepsis is difficult. It's not as easy as just checking a troponin. We'll review some of the new changes that have recently been published just last year, and then talk about how this could be applied during the short interval of care prior to arrival at the emergency department, and then talk about a few new tools that may be coming down the pipeline to help us in the future. So, as an epidemiologist, it's good to just describe the burden of sepsis and make us realize that there are millions of cases each year, and that this number happens to be growing. A group from the CDC is now reporting that this is even a greater proportion of our cases that come to the hospital, and of course account for a large proportion of our healthcare spending. You know, sepsis is everywhere, and it unfortunately accounts for many of our hospital deaths. This is data from Kaiser, which is a 21 hospital system in Northern California, who reported that 1 out of every 2 to 3 hospital deaths was linked back to infection and sepsis. Just a really incredible public health burden. And yet we don't talk about it. And so this sort of graph with multiple lines reflects what's can be drawn off Google Trends. And so it's tracking or sort of social media and internet searches for different words. And as you might expect, sepsis is not at the top of this list. In fact, our patients and the lay public are searching far more often for the word stroke or for heart attack. And yet, on the bottom, we see that the in-hospital mortality of our septic patients is actually twice that of these other acute cardiovascular conditions, if not greater than their sum, such that our patients may be dying of sepsis, but they don't know about it, and they're not trying to learn about it either. And so the burden is on us as sort of clinicians on the front lines to seek this out and ask the right questions. Okay, so why is this so hard? And so bear with me a bit. I'm going to take you on a little bit of a journey about this animal, which is called a platypus. And it's been a number of years since I've thought about this until I started reading children's stories. And there's a Richard Scarry story that has this quote, that the platypus is a big beak, webbed feet, a tail, and a fur coat like a beaver. And you can see the rest, many unusual characteristics. It is actually born in an egg. And yet, when we think about this from sort of the perspective of sort of a taxonomist or a biologist who's classifying species, you'll note that the platypus sort of has characteristics of mammals as well as birds. And it's sitting in what's described as something called a zone of rarity. And lucky for taxonomists, the platypus is actually quite uncommon, and there's not a lot of animals like this that sit in these zones of rarity. Okay, and so this sort of construct actually applies nicely about how we identify disease, right? So in the ideal case, there would be very few diseases that sit in this middle area, and that there'd be criteria that identify those birds or those mammals very discreetly with very few overlapping features, perhaps with patients who are healthy. And you know, we think about this moving forward. Ideally, the septic patient shown in this schematic would sit in one corner, and it would be very distinct from patients who have maybe chronic organ dysfunction, such as end-stage renal disease, and very distinct from patients who just have uncomplicated infection, shown on the right-hand side of the slide. And of course, very distinct from those patients who are actually quite healthy and not that sick at all. And yet the reality is the sort of the clinical cases we face look far more like this, where there's a lot of blending and difficulty trying to discern what is acute or chronic organ dysfunction, what infections are uncomplicated and will get better with one dose of antibiotics versus those that are destined to be lead to multi-organ failure and shock, like our case at the beginning. And so it's on this sort of landscape that we're stuck with lots of patients in these zones of rarity, these spaces in between, that makes classifying sepsis really hard, despite the fact that it's incredibly common. You know, the other issue is that making the diagnosis is incredibly time sensitive. And ideally, criteria to define the syndrome would be easy to measure and easy to use. And in fact, the hardest part then for those of us who consume definitions and criteria is that they actually change. And societies, professional societies, clinicians, doctors, nurses sit around and have discussions about what is or is not sepsis, and these things change sort of once every 10 years. And the obligation is then on us to sort of stay on top of that. If we think about the DSM for psychiatric diseases and syndromes, there's been 5 or 6 different versions, and they have criteria that change over time. So it's very similar for sepsis. And so this brings us to a recent effort that sort of concluded just about a year ago, in February of 2016, where a number of professional societies got together to re-examine what criteria for sepsis were, and then develop a new definition. And I think really when we talk about pre-hospital recognition, we need to start here with what expert consensus and research tells us to our best guess what sepsis is. And then we can think about how applying that to EMS. So this consensus group ultimately came up with something called Sepsis 3, which we'll go into. And the reason it was put together was because all of us who work in the ICU or the emergency department we're using a variety of terms to describe similar patients. We might be saying someone's septic. Maybe they have severe sepsis, or it was shock. This might be different when a resident's coming down and writing septicemia in the chart, or what a biller or coder is looking for sort of on the back end. This is confusing, and confusing as we talk between providers. It's even confusing as we talk to patients. A few years ago, Sepsis 2, as it was called, which was released in 2001, identified sepsis by something called SIRS criteria, or Systemic Inflammatory Response Syndrome criteria. And we'll talk about that in the end. But these have come under withering criticism for over-identifying patients who are sick, or perhaps may have just walked up the stairs and have both an elevated heart rate and respiratory rate. The sort of consensus group that got together identified that organ dysfunction was key to sepsis. Conceptually, it was key, but it was uncertain how to best go about measuring this. And another demonstration of the confusion is shown on the right-hand part of this slide, which is a meta-analysis of almost 30 studies, all of whom said they enrolled patients with septic shock. And yet you can see all of these black dots are at different places all over the graph, because patients otherwise thought to be similar may have widely disparate mortality rates, whereas one dot may show a mortality rate of 22% in a cohort of septic shock, and yet another cohort on the right-hand side of that column may have an 80% mortality for their patients. This was leading to a lot of confusion about what septic shock is and why. So this led to this manuscript, which was published in JAMA, that I think is worth reviewing if you have an interest in this area. And it's called Sepsis 3. And it goes through a new definition, meaning the words we would use. However, it offers some new criteria, and I think even shown here on the slide, a good definition to use with our patients. So they define sepsis as a life-threatening organ dysfunction that was caused by a dysregulated host response to infection. And that's a lot of complicated words that our patients might not understand. But when I'm talking in the ICU to a family member or to a patient, I say, you know what, sepsis, it's a life-threatening condition, and it comes about when the body's response to this infection injures your own tissues and organs. Okay, so with that definition and these important words, the question is then, what are the criteria we can use at the bedside? Well, those were also presented, and they were studied in large data sets. And so I'm going to take you just through a few findings from this research. And it mainly focused on identifying what organ dysfunction criteria will make up a patient who seems to be septic and discriminate them from a patient who ultimately is not. And we started with a list shown here on this slide. It's very difficult. The point is you can't read it. It's because it has about 25 different possible criteria. Things like oliguria or low urine output, maybe ileus, such as absent bowel sounds or poor gut motility, thrombocytopenia or elevated bilirubin. All of these different organs in the body come under threat when the patient's host response to infection injures our cells. And yet teasing out objective, easy to measure, and quick criteria from this list was the challenge. So a few things deserve some focus. The first was SIRS criteria, which were mentioned in a document about 15 years ago, something called SEPSIS 2. Other criteria that were proposed to look at include things like the SOFA score that you may not be familiar with as often in the pre-hospital phase of care. And then some other criteria called LODS, which is a very complicated score for identifying organ dysfunction, and then QSOFA, which is new and we'll get to in a little bit. All of these were looked at in great detail in a very large data set shown here, something over 1 million records that identified patients who lived and died both in the ICU and outside the ICU. And ultimately, in comparing these different criteria, the task force and the researchers focused in on something called QSOFA with this fancy little cartoon. And what QSOFA is stands for a quick sepsis-related organ failure assessment, or more importantly, these 3 clinical features. They were identified, again, in these large cohorts of existing data as clinical prompts or features that identified those patients who already had infection suspected, meaning they already had a culture drawn and were already administered an antibiotic, that were at highest risk of a bad outcome. And there were some thresholds that were used, such as a GCS less than 15, respiratory rate greater than 22, and a blood pressure that was less than 100. The great thing about QSOFA is that it has no laboratory tests that were required, and all different types of windows around the time of infection suspected were okay to measure these, meaning you may see a sick patient and see that they have QSOFA, and then start thinking about infection. Well, that patient might be septic. On the other hand, you might take a history and hear that they've had subjective fevers, been coughing up purulent sputum, and then when you take vital signs, you realize that they have 2 of these QSOFA findings. Well, then that patient might be at higher risk of sepsis. Okay, so this is called a power rule. And what it means is the numbers sort of on the right side. That while only 1 in 4 of patients with infection have 2 or more QSOFA, those patients tend to account for 3 out of the 4 deaths. Right, so these are important features that have important prognostic information for a bad outcome that's in the future. So you might ask yourself, well, I've heard about lactate quite often when taking care of septic patients. In fact, some EMS agencies are measuring lactate in the ambulance. Well, so did lactate at all add to QSOFA in these analyses? And as shown in this graph, particularly the one on the right-hand side of the slide, you see what's called a receiver operating characteristic curve. And this is a statistical display of how well these tools discriminate between a patient who's likely to be septic versus one who's not. And as you look at these different curves, you'll see that a model using just clinical things like age or the patient's race or gender is shown in black. And the closer this curve is to that gray straight line, the less well it does in discriminating patients who are or are not likely to have the outcome of interest. And yet, as we move up the curve, further up to the top left-hand corner, you'll see that there's a tan and then a red curve. And these are models that do and do not include lactate. And so the take-home point here is that in these large data sets, lots of patients and lots of clinical measurements of lactate and QSOFA, the lactate or the red curve really made no change at all in the ability to separate septic and non-septic patients. In fact, lactate is also sometimes expensive to measure with devices that are hard to calibrate. And there's a lot of pragmatic reasons why it's nice that that test didn't show any statistical benefit. And so SEPSIS 3, again, a document worth reviewing if you have an interest in this area, defines sepsis using words, that it's a life-threatening organ dysfunction when the body's response to infection injures its own tissues and organs. And the clinical criteria involves something called SOFA. That's mainly for use in the hospital, but for outside the hospital or in the emergency department, there was a lot of focus placed on quick SOFA or QSOFA. Okay, so what's great about this? Well, this group and all of the multiple societies around the world who endorsed the criteria were trying to now speak the same language. They took out otherwise redundant terms like severe sepsis, which are thought now no longer to be part of the lexicon or even part of your clinical language that you use with patients or doctors. And they also presented objective criteria for how to identify organ dysfunction. These were data-driven conclusions. Sepsis 3 did not come about solely from older white men sitting in the room, but in fact, through a lot of dedicated research over many years. But is there any confusion? For those of you, again, really into sepsis, you may note that our hospitals are mandated by CMS to provide specific types of care in specific windows of time. And yet they're identifying sepsis using a different set of criteria put forth by Medicaid and Medicare. We also might note that the CDC, who's taken a great interest in sepsis within the past 12 months, has put forth their own criteria in September. And so all of these different criteria are for different uses and for different reasons. And we just need to be mindful of that when thinking and talking about them so that we don't talk past each other. It's also worth identifying just quickly that the task force in Sepsis 3 doesn't tell us as clinicians how to identify infection. That's still left up to us. Infection can, of course, attack multiple parts of the body, whether it's the skin with cellulitis, the abdomen for abdominal infections, often in post-surgical patients, or most commonly lung infections in those with pneumonia. All of these different infections themselves have different criteria, and we just need to keep on our clinical thinking caps in looking for those people. Okay, so what does this mean for EMS? Well, a lot of what I've just talked about is really in this time interval. When a patient arrives to the ED, and during those earliest phase of care, we're making assessments and sending off labs. And yet there's a longer window in which we may be able to advance recognition and move this out to the time of first medical contact by most of you and your colleagues. But you might ask yourself, I don't know, I see a lot of patients with stroke. We're transporting a lot of patients maybe with chest pain. How often does severe sepsis really make it into all of my runs during the day? And so this is from King County EMS. And this graph shows all of the EMS encounters in King County, Washington, which is something like the 15th largest county in the US, and then tracks what these patients ultimately were diagnosed with when they got to the hospital. And you see that consistent with the increase over time, that our severe sepsis encounters during pre-hospital care were actually twice as often as those with acute myocardial infarction or stroke, such that for every 4 patients with these acute cardiovascular diseases, the paramedics at Medic 1 and King County EMS were seeing 8 patients admitted with severe sepsis. And we conclude that therefore, and hopefully you'd see this in your own practice, infection and sepsis is accounting for a large proportion of the people you take care of outside of trauma and other sort of minor complaints. Okay, so of sepsis patients, it's worth noting that most are coming from the community. Although patients with nosocomial or hospital-acquired infections often get a lot of press and often have dramatic, highly resistant organisms, the bulk of sepsis is coming from the community. And of those community septic patients, they're being transported by you. So then you'd ask yourself, well, if I need to start thinking about sepsis and different criteria during pre-hospital care, how much time are we actually spending with these patients? And so this graph, it's a histogram, which is a sort of a frequency bar chart, which is showing time on the x-axis from when a paramedic first encounters a patient, and this is in Pittsburgh, city of Pittsburgh EMS, and how long it took from the moment that paramedic was at the bedside or at the location in which the patient was first encountered until the antibiotic was administered in the emergency department. And on average, in the city of Pittsburgh, that was almost 4 hours. And so you'd say there really could be an opportunity here to move recognition earlier and perhaps affect a chain of care similar to what's been done in stroke, AMI, or trauma. Okay, so this is a survey from a long time ago, and hopefully you guys in the audience would have similar or even better responses to this, hopefully even after this talk. But many years ago, we asked all of the Medic 1 and King County EMS folks in Seattle, as well as some AMR, which is a private ambulance company, to just fill out a survey about their knowledge of sepsis and sepsis treatments. And what was a good starting point was that our paramedics and our firefighter EMTs, most here, almost 90% of them had heard of the word sepsis. And this was far more often than those in the US and the general public through different telephone surveys. Okay, but when we ask these pre-hospital clinicians to identify the correct definition and then query if in their own opinion the diagnosis is missed some or a lot of the time, we're seeing some really concerning findings here. And so it encourages us to talk about sepsis more and to try to learn about sepsis 3 and how it can impact your care. Okay, so what would we ideally want for sepsis recognition? We want something simple, cheap, meaning it's not have costly lab tests. And all of you have your own clinical suspicion for infection, but we'd like to augment that in some way if possible. We'd like to use criteria for pre-hospital care that are consistent with guidelines in the hospital, so we're identifying the same types of patients, and also embrace the fact that there is going to be some uncertainty, that there will be missed cases, or there may even be over-identification of cases. And for something like time-sensitive sepsis care, that's probably okay. Okay, so some researchers have spent time doing this. Carmen Polito, shown in this citation, is from Emory, and she's worked with a number of EMS agencies in Atlanta. This other paper is from the German Sepsis Society. The Europeans are particularly aggressive in pre-hospital care, and even put clinicians or physicians in their pre-hospital response. So there's a lot of research here in how to build models that have different criteria. But this is probably the types of things we want to think about. You know, there's two axes that we mentioned when going over the definition. The first one was organ dysfunction. You know, organ dysfunction at the bedside, we can sort of look at a patient and say, this guy is sick. You know, but if you looked at QSOFA or you looked at a shock index, you could probably quantify that objectively. That's probably the easier thing to adapt to pre-hospital care. But this infection, present or absent, the horizontal line, dotted line here, is probably the harder one. We have very few clinical signs that tell us a patient is infected, other than our history, physical examination, and perhaps fever. And yet many older adults, of course, because of immunosenescence, won't mount a fever, and in fact may become hypothermic, particularly during the winter. So that one's going to be harder, and we may not have an answer sort of at the end of the talk for that. And so it takes us back to QSOFA. Could QSOFA work in the ambulance, at least for organ dysfunction criteria? Well, it was cheap. It's fairly easy to remember. It does not help us with the infection, yes or no axis. And it may not find all the patients, but certainly it'll find those at higher risk. And so Sepsis 3 and that group we talked about earlier had decided that perhaps a threshold of 2 or more QSOFA points would be a good starting place, at least because it doesn't identify everybody. And of those that it does, 1 out of 4 of those patients ultimately went on to not survive their hospital stay. Okay, was it tested in pre-hospital data? Well, in all of that research that we talked about and almost 1 million patients, this dot in that graph that's in JAMA reflects about 10,000 pre-hospital records that were studied and validated QSOFA. And so at least back in 2016, and there have been a variety of other validation studies published, have been looking at these criteria in patients just like the one that you transport every day. Okay, so back to serum lactate. Well, we showed that it doesn't add a lot to QSOFA, but what about its role during pre-hospital care? There was a previous questioner before the talk even got started that brought up lactate, and it's worth noting that lactate, serum lactate, when measured either arterial blood, venous blood, or with a point-of-care meter, is highly prognostic of a bad outcome. This is a model that's just showing as lactate increases along the x-axis, that one's adjusted odds, or their odds of death, with a high lactate versus a lower lactate, steadily increases. And this is the case if the patient's in shock or not in shock. So what are the potential benefits or sort of pro-con here for lactate during pre-hospital care? Well, again, it is also relatively cheap. It requires a device, usually a measurement stick, and then ongoing calibration. It does have an incredibly strong association with organ dysfunction, and it is well validated in the emergency department and the hospital. And yet there are some cons or some difficulties with lactate here, in that these meters and devices are actually hard to find. They are not all CLIA certified or approved for clinical use. There's a lot of different tools that you may be approached by different vendors and industry partners to use these measurements for research, but yet they're not all certified for making clinical decisions. And there's actually conflicting data on their utility. There's a number of studies here, we won't go through them in detail, but the greatest experience with serum lactate or point of care lactate during pre-hospital care is actually not with sea transports, but with helicopter transports, particularly in large metropolitan systems. And yet the number of patients who've been studied in many of these is quite small. The largest one here is Frank Ayette here at University of Pittsburgh in trauma patients, only about 1,000. Okay, so here's some of that data. Again, it's just showing, again, one of these curves that's telling us how much does lactate improve our prognostication for patients above and beyond clinical data alone. The model with lactate is the dotted line. The model without it is the black line. And you'll see that they actually almost superimpose. And despite all the effort we might go through to buy the devices, keep them calibrated, buy the test strips, train and implement this across our agencies, we may not be getting a lot of decision-making bonus out of all of that work. Okay, so what else is coming down the pipeline? And there's a few slides here left of the talk, and then it sounds like we may have some questions. So recently, folks have said, well, in the hospital, there are a variety of measures of patients' inflammatory response, such as their cytokines, things like IL-6 or IL-10, that are released by macrophages and other inflammatory cells when an infection takes hold in the body. There's also biomarkers such as procalcitonin, which you may have heard, that is greater in patients with bacterial infection as opposed to viral infection or no infection at all. And so what about measuring these during pre-hospital care? And so that's really been some cutting edge research here in Pittsburgh and elsewhere that is probably not prime time, but it's worth noting in that there are folks who are starting to sample blood from patients during pre-hospital care prior to any treatment, and then looking for these biomarkers of sepsis and seeing if they can discriminate the patients accurately or not. And so some of this data is coming forth. There's a recent cohort here in Pittsburgh of about 400 patients where 20 cc's of blood was drawn, and then a variety of these inflammatory cytokines, IL-6, TNF, IL-10 have been measured and compared, as shown in this graph. It's a little busy, between patients who are septic versus not septic at all. And if you look at the graph that's labeled as IL-6 there in the third panel over, S3 or sepsis 3 on the x-axis corresponds to the septic patient, whereas none corresponds to the patient who had neither infection nor organ dysfunction. And although this is a small study, it does hint at that some of these more costly or complicated biomarkers can potentially discriminate these patients even at the earliest phase of care in the ambulance. Now, there's a lot of pragmatic steps that are missing between taking these tests out into the pre-hospital phase, but this is where the current research is. Okay, so what's next? And I think this is nearing one of my last slides, is that although we put forth the definition and showed criteria that may or may not be adaptable to pre-hospital care, it's worth recognizing that not all sepsis is the same. We started off by saying a lot of patients may have significant comorbidities, whether they're a renal player or a cirrhotic. They may have very different infection types. Influenza may take hold extremely quickly with a very robust inflammatory response. And this could be quite different than an indolent infection, perhaps with a patient with an epidural abscess that's been brewing in an intravenous drug user for many weeks. And it's only finally the tipping point where their organ dysfunction or their encephalopathy or shock has gotten so bad that they present and call 911 or else found down somewhere on the street. Sepsis is not all the same. And there are groups or phenotypes of patients inside this very broad term that we need to start thinking about. And although they don't yet, at this time, have different treatment algorithms or things that we'll do differently for them, as we'll talk about in our next session, it's worth noting that a number of groups are starting to research different phenotypes of sepsis. And so this picture at the bottom gives a hint at that. And so these are cord plots, which are taking clusters drawn from clinical data and that otherwise patients look the same on the surface, but looking at their lab tests, their vital signs, and some of their biomarkers underneath, machines using machine learning can group these patients into clusters or phenotypes. And then shown in the numbered plots on the right side, these different colored clusters have very different variables that bring them together and are very similar. Such that this dark blue cluster in number 4 has a lot of shock and liver dysfunction, and that's quite different than the group perhaps in the dark green that's looking at variables on the left side and is clustering together because of things like age or renal dysfunction. And so in a way, that's the future. I think I might have lost my concluding slide there, but certainly we can conclude by emphasizing again that sepsis is common and deadly. During the pre-hospital phase of care, you're likely seeing sepsis far more often than patients with chest pain or acute cardiovascular disease. And there's a measurable window of time in which to think about recognizing these patients. Important steps for sepsis recognition will include your own clinical acumen for infection, but then testing, implementing, and even trying out some of these newer organ dysfunction criteria that are things like QSOFA, such as altered mentation, elevated respiratory rate, or low blood pressure, that in combination tend to identify the sicker patient. There are fun new tools that lean on sepsis biomarkers such as lactate or procalcitonin, things we use in the hospital. They're being studied during pre-hospital care. We just aren't ready for prime time. And so with that, I'll wrap. I think that hopefully will set a nice foundation of how we might recognize sepsis and set the stage for what's about coming in our next lecture in a few weeks about what we would do with this information and what treatments we can do now and what treatments are being tested for the future. So thanks for your attention.
Thank you, Dr. Seymour, for a phenomenal overview of sepsis recognition, for your slides, and for sharing your expertise with our cohort today. At this time, I would like to invite participants to submit any questions that you may have through our chat box feature. We do have some initial questions that we'll go through. The first question is, where can we find the Sepsis 3 document that you referred to? And I think that the caller might be referring to the third International Consensus Definition paper. If so, we do have that available on our website under resources. There is a link to that article.
Yep, sure. Can you hear me, Jim?
Yes.
Okay, great. So there's some great online resources. An easy one to remember is qsofa.org, which is a website hosted at Pitt that puts all of these manuscripts available for you. There's no login, there's no cost. It takes you through a lot of what was done in Sepsis 3 and also has some neat videos, sort of whiteboard marker videos that I think you might enjoy. At the same time, the publisher, JAMA, Journal of American Medical Association, has a website, jamasepsis.com. I think that's all one word. That also really collates most of the major papers about sepsis in the past 5 years or so. A number of really fantastic review articles that go over many of the things we talked about. I would recommend checking that out.
Thank you. Our next question is, how much has end-tidal CO2 been investigated for pre-hospital sepsis?
Yeah, not as much as you'd think. There are some pragmatic issues with getting those measurements on all our patients, and they've tended to be studied in smaller cohorts. So at this time, although end-tidal may have a role, particularly in cardiac arrest and resuscitation, and received a high level of interest in that space, it wouldn't at this time be recommended as any part of criteria for organ dysfunction in the septic patient.
Thank you. Our next question is, are there any sepsis screening tools that you are aware of that EMS are using consistently?
Yeah, consistency is the magic word there. Many EMS agencies, there's a group in Denver that has a protocol that's pretty active. Greenville, South Carolina has another protocol with some criteria that they've implemented. These are usually available on the web. But it is true that there has been no consistent clinical guideline put forth by the professional societies of different pre-hospital groups to say this is how we will or will not identify sepsis. I think different groups are implementing QSOFA in addition to suspected infection. Others are still using sort of a modified SIRS. And then, of course, in the United Kingdom or the UK, where they have the Sepsis 6 and different criteria that have been put forth by the UK Sepsis Trust, that's probably also worth looking at.
Thank you. Our next question asks, what is your position on pre-hospital administration of antibiotics?
Okay, great. Well, full disclosure, I'm sort of co-PI on a trial, as I mentioned, in Ontario that's testing pre-hospital ceftriaxone. And so, you know, to be intellectually honest, I don't know the answer of that. I think there's a lot of preliminary data that would suggest moving antibiotics earlier in the phase of care saves lives. This is what we reported in the New England Journal just last May, that even 1 hour advancing antibiotic in otherwise similar patients with sepsis was associated with a 4% reduction in their odds of in-hospital mortality. That's a measurable change in their outcome if we can get that vancomycin or their ceftriaxone into the patient sooner. Of course, that data from the entire state of New York was an observational study, and patients were not randomized. And so you might ask yourself, let's randomize these people. And that's something really hard to do in the hospital. There's been a group in the Netherlands, I think it was called the PHASMA trial, that was just published in Lancet about 2 months ago, that looked at pre-hospital ceftriaxone or levofloxacin in a group with 2 or more SIRS criteria, a fairly low acuity cohort. And as you might expect, in that trial, they found that antibiotics were administered sooner in the treatment arm compared to the group that got antibiotics in the hospital. And it was a sustainable difference, but that did not change their overall in-hospital mortality. So as the way things go, one Dutch trial doesn't always answer the question, and usually to move the needle, most research groups, there'll sort of be one per continent that tackles this question, funded by different federal governments, and NIH and whatnot. And so I think there's going to be a US trial that complements the Canadian trial, and we'll likely have that sorted in 3 to 5 years.
Thank you. The next 2 questions are somewhat related, Dr. Seymour, so I'm going to ask them simultaneously. And that is, as providers become more aware of this information, is there any thought that the CMS criteria might change from SIRS criteria to the use of QSOFA? And the other question that is related, which is, how are other hospitals using the QSOFA and SEP3 definitions concurrently with the requirements of CMS? The CMS requirements of meeting criteria is different than QSOFA, and this makes meeting CMS requirements very confusing to our physicians and staff. So they're somewhat related questions.
Right, and these are those are great questions. I think we've been hearing them for a couple years now, and there's no answer. In fact, every hospital in the United States who has clinicians at the bedside that need to identify their patients, unfortunately can't use the CMS criteria, because CMS, the Centers for Medicaid and Medicare Services, are providing quality improvement metrics and performance measurements, publicly reporting those, tying those to financial payments, and doing so in patients who are already discharged from the hospital. So they use ICD-9 or ICD-10 diagnosis codes from discharge to identify sepsis, and then track back and look at how these patients were cared for. So it's a really challenging thing to then map those criteria to the bedside. Plus, as was mentioned by the questioner, they're using SIRS criteria. And SIRS, of course, can be criticized in multiple different ways, and they're also really good in other ways, in that fever and white count are fantastic markers of infection. This sort of the conflict between CMS and what is reported in Sepsis 3 has been present for 2 years, and I unfortunately don't see that going away anytime soon. In part because CMS has a very diligent approach to their guidelines and how they build out their performance metrics. We haven't seen any sense that they'll change those. And so as clinicians and hospital administrators, quality improvement officers, we're stuck trying to educate our people to think about QSOFA and Sepsis 3 as clinical prompts, but then also be mindful of SIRS and somehow perhaps use their electronic alerts to find these patients to make sure they're getting antibiotics in a timely way.
Thank you. Our next question is with respect to the medical community, and in the medical community, is QSOFA considered controversial thus far? The criteria seems to be more reactive than proactive, the caller states.
Yeah, so I think we're all in the medical community, including hopefully whoever's on the call. To say that Sepsis 3 has been controversial would be an understatement. It's actually probably the greatest benefit of Sepsis 3 has been raising awareness of sepsis. Probably one of the most viewed papers in JAMA of all time. Millions of people have read and have thought and discussed the criteria. Now, their scientific validity has been looked at in multiple subsequent studies, also published in high-profile journals. And so there's been little critique, I think, of the science and the methods that went into deriving them. But there certainly is a controversy about how they best can be applied at the bedside. And so what I mean is that the research that was done to present Sepsis 3 and encourage us to use SOFA and Q-SOFA was among people who had already received a dose of antibiotic, had a culture drawn, and in whom infection was suspected. And yet often, particularly in pre-hospital care, but then even in the emergency department, or if we're up on the ward at a rapid response, we're seeing patients who haven't even yet been treated. We're looking for primary screening criteria in whom we want to both suspect infection and identify organ dysfunction all at the same time. And that's particularly tricky, and perhaps why a combination of SIRS, whether it's fever or white count, pandemia, and some of the findings in Q-SOFA may be the way forward. But that at this point hasn't been teased out or tested, although a number of groups are sort of looking at combination criteria.
Thank you. There was a question submitted prior to the talk regarding point of care testing for lactate. And the question is that the caller has found point of care lactate falls under a moderate complex test and would therefore require CLIA, which is Clinical Laboratory Improvement Amendments, regulations and guidelines, whereas the glucometer may have a waiver. She wants to know if this is not covered during, since you covered it during the presentation, she would like to know if EMS are performing point of care testing for lactates in the field, and if so, how are they handling quality control, and are they able to obtain a waiver from CLIA?
That's a great question. So many of the point of care lactate testing that I'm familiar with are actually using older devices called the Lactate Pro. These are devices which are no longer being sold, and many of them are actually holdovers from what was formerly called the Resuscitation Outcomes Consortium, or the ROC, where lactate pros were used as part of research to take care of trauma and cardiac arrest patients. There very well may be other devices that have been put forth, but most, if any, are not yet CLIA certified, and therefore there are some barriers to their regular clinical use. I think the calibration and the ongoing QA of these devices is extremely important. We found even in our own research that there's quite a bit of difference between the point of care measured in the field versus what's obtained in the emergency department from an arterial stick. And even, over the course of weeks, these devices will need recalibration. So I think there's a lot to be learned there, both from a regulatory perspective as well as the ongoing management of the device. And that's something to consider when the data is telling us that maybe these tools aren't giving us a lot more information beyond just some of the clinical signs that we talked about.
Thank you. Our next question is, are there unnecessary consequences to operating on a clinical impression of sepsis in the field if, in fact, sepsis does not exist?
Right. Another great question, really getting at what if your criteria, whatever they are, over-identify the septic patient? And I would say that answer relates in a bit to what are we going to do with that data? And we're going to talk about that in our next session as it relates to treatment. But to the extent that your treatment is cheap, low risk, and not a burden on your pre-hospital clinicians, I don't have a lot of concern about having a higher than normal suspicion for sepsis, even if the patient turns out to just be dehydrated. So what I mean is, if you think sepsis is present using some set of criteria, and what you're going to do with that information is call ahead, that's probably fine. On the other hand, if you have an experimental drug, something that's an immune modulator, maybe a big slug of steroids, of course, which was just shown to have no benefit in sepsis, that's a problem. And you need to make sure that we're tailoring what are called the operating characteristics or the sensitivity and specificity of the criteria that you want to use to what you're going to do with the information. And I look forward to getting into some of that on our next talk.
Thank you. There was a comment that was posted that states that the IV fluids given by EMS can count toward the 30 milliliters per kilogram required in the sepsis bundle that is included in the emergency department, and it's credited as such. Our next question is, how do you balance the concerns about antibiotic stewardship versus early intervention?
Right. Another good point. This is often mentioned when we're thinking about advancing, particularly antimicrobial therapy to populations that are otherwise on the margins. The way I think about this is maybe a little bit skewed, but there have been no studies to at this point that have shown us that sort of the antibiogram of a hospital or a health system has been changed as a result of SEP1, for example. But that would be a fantastic bit of data to get, and not just on a hospital level, but on a region or a state level. That would involve really great discussions with, you know, your infectious disease and antibiotic stewardship teams, right? We would like the rollout of SEP1 or even some pre-hospital antibiotic intervention would be in partnership with your antibiotic stewardship program or those folks who are highly interested in that area in order to really study it. I'm not aware of any data at this point. But from a clinical perspective, one must think about the sheer volume of antibiotic doses that are given prophylactically to patients who are getting, you know, any type of neurosurgery, ENT surgery. Maybe they're having a variceal bleed and are recommended to get ceftriaxone to prevent SBP or secondary bacterial peritonitis. Right? These are patients who have an extremely low risk of getting an infection, and yet we're administering these single doses of antibiotics all the time without any worry. And here we're talking about being worried about giving a single dose of antibiotics in an early phase of care to a patient potentially in shock with a mortality rate of 25%. And so they're very, very different clinical scenarios, and one has to think about our risk threshold for a single dose of antibiotics. And if we're really comparing apples to apples here when having this discussion. So at least that's my perspective. I give antibiotics all the time in the hospital for indications that aren't nearly as interesting as a patient dying of shock. So I'm all for testing it and seeing what we find out.
Thank you. Our next question states, have there been any studies that show a change in overall antibiotic usage with the introduction of a sepsis protocol? More early leads to less later and less overall?
So a good question about practice patterns and how they relate to the implementation of sepsis protocols. So I guess my own experiences with the state of New York, where over many years there was a mandate that all hospitals had to use protocols. And that, of course, had some controversy at its initiation. And yet over time, protocol use increased from about 50 to 70% across the state. Patients were administered antibiotics on average within 1 hour across all 150 so hospitals or so, which is far shorter than in prior years when there was no protocol. So I think, you know, there have been other studies. In fact, there was most of these are tied to the Surviving Sepsis campaign, of which I was not involved in their research, but there's been a countrywide implementation of sepsis bundles in Spain that was published in 2007, also in JAMA. So lots of good data that shows protocols and bundles will get things done faster and potentially even have benefits for patients like we found in New York.
Thank you. Our next question is, any thoughts on IV vitamin C and sepsis treatment?
Right. So again, this is a therapy that has been discussed particularly in the media, the lay press, and gotten a lot of attention, I guess, for about a year now as a result of data from Paul Merrick at Virginia Commonwealth. Remember, vitamin C in the Merrick protocol, as some people refer to it, was administered with thiamine as well as a dose of steroids in a very small observational study with almost unbelievable results that have yet to be validated. So I don't use vitamin C in my clinical practice. I may be a skeptic and not an early adopter, but some view those findings as super controversial and are yet worthy of further study. So there are folks investigating this just in Boston who have a large trial being initiated for particularly the thiamine piece, and more trials funded by NIGMS and NIH that are tackling this, I think in Virginia and multiple centers on the East Coast. Again, so we'll have to stay tuned.
Thank you. Our next question, I believe, refers to what is asking you what you feel the greatest benefit of EMS sepsis alerts might be. The question is stated as such: do you foresee the greatest benefit of EMS sepsis alerts as identifying sepsis or possible sepsis, and perhaps elevating the triage level 1, 2, 3 high, 3 low, 4, 5, and getting resources into that patient room sooner, such as getting the serum lactate entering into the sepsis care path quicker, and thereby receiving IV antibiotics and perhaps even admission faster?
Well, that's the easy answer. It's yes. I think we'll talk about this on the next hour, that pre-hospital recognition could lead to multiple different steps, some of which are cheap and easy, such as calling ahead and advancing the care team in the hospital. Others are a bit more challenging and involve direct intervention at that moment during pre-hospital care, and there's a variety of things that could be used for immediate intervention. Maybe it's vitamin C in a couple of years, I don't know. But those are harder and are going to take more time for us to incorporate into practice. So yeah, I think I would agree with the questioner and say let's talk about it next time.
Well, thank you so much. Those were all of the questions that had been submitted, and I did want to just take a moment to thank everyone on the line for joining us today. And just as a reminder, our next call will be held on Wednesday, February 21st at the same time, 11:30 a.m. Eastern Standard Time, where Dr. Seymour will address pre-hospital treatment of sepsis. So the focus will be upon treatment. Dr. Seymour, thank you so much for sharing your time and your expertise with us. Audience, thank you for joining us, and we look forward to having you join us in February again. This concludes today's call. Have a great day.